So welcome everyone to today's CHET conversation on the intersection of intimate partner violence, pregnancy, and mental health during COVID-19. Reminder, again, just make sure you mute your audio and video unless you are a panelist or you will be speaking or presenting today. And make sure that you submit your questions throughout the webinar to the co-host. It can be either myself, Araceli, Samantha, or Ivy Long. You should be able to send questions and we will bring your questions up at the end of the webinar. Also, we do have an upcoming CHET chat next week titled Who's Next? Using Network Science to Understand and Do Something About America's Gun Violence Epidemic. This will be featuring Dr. Andrew Papachristos. Again, next Tuesday, May 19th, same time as today's webinar, 12 p.m. And Dr. Papachristos will explore how network science might help us better understand gun violence in American cities. This talk explores how mapping and analyzing social networks can help predict the victims of gun violence in U.S. cities, as well as offer possible pathways to guide gun violence prevention efforts. The talk will also touch upon how responses to COVID have impacted violence prevention efforts in Chicago. And you can go ahead and register using our bit.ly link, bit.ly/chetchat519. Also, I've been mentioning our podcast. The center does have a podcast titled Skinny Trees Lift Health for All. We currently have an ongoing mini-series titled COVID-19 in our Chicago communities. So we're talking to different communities in and around Chicago about how they're being impacted during COVID-19 during these times. I believe we have 4 episodes out and we have a lot that are already pre-recorded. So if you have some extra time on your hand, make sure look us up on Apple Podcasts, Stitcher, Google Play, Spotify, or wherever you listen to your podcasts. And you can also find us on skinnytreespodcast.com. And for today's CHET conversation, the intersection of intimate partner violence, pregnancy, and mental health during COVID-19, the American College of Obstetricians and Gynecologists, ACOG, reports that 1 in 6 abused women first experiences abuse during pregnancy, and COVID-19 may increase domestic violence rates for those who are trapped in home with their abuser. In recognition of Maternal Health Awareness Month and Mental Health Month, thank you for joining us today for a conversation with a panel of community leaders about the intersection of intimate partner violence, pregnancy, and mental health with a focus on women of color. Our faculty director, Dr. Melissa Simon, will moderate this discussion. And to introduce some of our lovely panelists, we have Rachel Hines. She is a licensed clinical social worker with a master's degree from the University of Illinois at Chicago. She has been in the field for 12 years with a focus on providing relational, trauma-informed therapy for children, adolescents, adults, and families with a variety of different needs and supports. As one of the YWCA's clinical program coordinators, Rachel supports a team of therapists in addition to providing individual family therapy. She is trained in eye movement desensitization processing, EMDR, child parent psychotherapy, CPP, dialectal behavior therapy, DBT, trauma-focused cognitive behavioral therapy, TFCBT, as well as a qualified supervisor in the state of Illinois with reflective supervision training. She believes in engaging in a collaborative process that is client-centered and empowering. Our next panelist, Radhika Sharma Gordon, manages education and training for Apnagar, a Hindi Urdu phrase meaning our home. Apnagar was founded in 1989 in Chicago to serve the legal counseling, advocacy, and housing needs of immigrant survivors of gender-based violence. Radhika obtained her BA and her master's in public health from the University of Michigan. Since 1989, she has been working and volunteering in Chicago, addressing disease, violence, the need of immigrant communities, women's empowerment, and positive youth development. Radhika is also an adjunct instructor in community health and wellness at Northeastern Illinois University. Our next panelist, Linda Tortolero, is delighted to serve as president and CEO of Mujeres Latinas en Acción, the nation's longest-standing Latina organization. She builds strategic relationships with stakeholders and carries out Mujeres' strategic plan to address effectively the immediate needs facing Latinas and their families. Under Linda's super leadership, Mujeres is a fierce advocate on key issues such as gender-based violence, women's health, and economic security, immigration, and reproductive justice. Most recently, Mujeres opened up a new Brighton Park office with its partner Esperanza Health Centers, AFQHC. Linda serves on the Action Council of the Illinois Coalition for Immigrant and Refugee Rights and the steering committee of the city's clerk Chicago Status of Women and Girls Working Group. She was also a member of Mayor Lightfoot's Health and Human Services Transition Committee. Welcome to our panelists, and welcome Dr. Simon. And with that, I will let Dr. Simon get started.
Hello, everybody. Thanks for joining us today. I'm so happy, and I'm sorry I'm in a mask. I'm in clinic, but this is my face. Not supposed to touch the mask, so I'm not displaying the right behaviors, but that's all right. So what we're going to do first is kind of discuss some basics about intimate partner violence. So I would like each of our esteemed panelists to be able to give like an overview of intimate partner violence from your organization's perspective with respect to the clients that you touch in the particular communities that you are working in, and go from there. So, Radhika, do you want to go first?
Apnagar, our focus has been on serving immigrant and refugee communities that are suffering from intimate partner violence, and that's the primary work that we've done over the last 30 years. We have also broadened into the southwest side of Chicago and Skokie and Swedish Covenant Hospital, where we have a partnership. And so we are also serving people who are not immigrants and refugees, but our primary focus has been on the complex legal and emotional and cultural and linguistic needs of immigrants and refugees. Our primary client base originates from Asia, Africa, and the Middle East. And so we have a staff that at any one time, depending on our staffing, speaks 8 to 18 different languages. And our legal department, like many of the other sister agencies, has had to, our legal advocates have had to develop not only expertise in the Illinois Domestic Violence Act and the Violence Against Women Act, but also understanding a lot about immigration law, as well as a lot of the other complex issues that immigrant and refugee survivors of gender-based violence, whether it's partner violence, elder abuse, adult children who are being abused by their parents, female genital mutilation, people who are having to seek we've had a client who was having to seek refuge because they are trans and their country and their families were prejudiced against them and they were having to leave for their safety. So we were able to provide a trans woman space in our shelter and as a client. And then we also have had clients else in the family, perhaps a parent-in-law. So just all the complexities of multi-generational immigrant families. Those are just some of the many issues that we address.
Great, thank you. Linda, you want to go next?
Hi, good afternoon, everyone. So Mujeres Latinas en Acción has been serving domestic violence survivors really since its inception. primarily we had started serving young people who had been fleeing homes, who had been witnesses to domestic violence or child abuse, or survivors themselves. And today, domestic violence is our largest program. We don't operate a shelter, but we provide various service modalities, individual counseling, group counseling, therapy for children who have been witnesses to domestic violence. And we also provide an intensive approach and therapy for those survivors who may also be suffering some sort of mental health condition, either triggered by the violence or something that preceded the violence that they had endured. We find that our best approach is really working with the survivors as where they are at. So the bulk of our survivors are Spanish speaking, but we are seeing a change. We are seeing that the younger generations are more comfortable in English, and that's something that we've been adapting to. All of our staff are bilingual, but again, we were dealing with a very emergent immigrant population. What we are seeing now is that with net immigration from zero, net zero immigration from Mexico, that more of our survivors actually that are coming have been here for many years, so they're undocumented, have been so for their children's lives, their lives. But we're also seeing that there has been a small uptick in survivors from Central America and South America as well, and that's something that we are also trying to work with. We serve men and we serve transgender survivors as well, both in our domestic violence and our sexual assault. And we find that we have had a wonderful reputation in the LGBTQ community. So we always receive referrals from those organizations that are looking for services for that population as well. And Mujeres is always trying to adapt to what we see on the ground in terms of our community. So especially with regards to immigration, and making sure that if they are survivors and they qualify for VAWA, Violence Against Women Act or Victim of Crime Act funds, that they do receive that, as well as the U visas.
So just a follow-up question on that. So undocumented could qualify for funds under VAWA?
So there, in terms, I should have clarified a little bit better. What it is that they can qualify for services. So all of the organizations that are domestic violence organizations in the state of Illinois and across the country, we do not ask your status in order to receive services with us. So all of us have VAWA or VOCA funded staff, almost always.
Okay, and is there concern specific, a little bit more in the concern area around undocumented or non-citizens or new immigrants if they want to leave their U.S. citizen partner? Or do you say just because you don't ask, then it's not an issue? Is that?
Right, I think it's a case-by-case scenario. That's always a safe bet to say, but I think in general, one of the things that we do see happening, and we've seen more under the Trump administration, that the person who is causing harm, the perpetrator, may say, if you don't stay with me, or if you leave, or if you take my children away from me, or if you do this or that, I will call up ICE. And it's often the case that men may have status of some kind where the women may not. And that's because of the migration story from wherever their country of origin is. So we are seeing that. But in general, I think that because of the citizenship question and residency, there's just more heightened fear to leave your abuser, no matter how difficult the situation it is.
Thank you. Rachel, can you speak a little bit to the community or the clients that you work with and the issues that you're seeing? I think you're
She's
on
mute.
Mute.
Sorry, can you hear me now? Sorry about
Yes.
that. So at the YWCA Metropolitan Chicago, we serve, the broader Chicago area, including the suburban area, and a wide variety of populations. The program that I sit in specifically is the SESS program, which is the Sexual Violence Support Services program. So I coordinate the counseling programs at our Chicago Heights location in the south suburbs, and our PMC location, which is located in Addison. And what I started with the Rise Children's program in the city, which has done a lot of work with Mujeres, and we've had staff from Apnagar, so I'm familiar with both your organizations, which are phenomenal. And so in terms of who we serve kids as young as 3 who are survivors of rape, incest, trafficking, and their non-offending significant others. So that can be siblings, caregivers, like which could be parents or non-parents, adoptive parents, grandparents, etc. And we serve all the way through the lifespan. So we have folks as young as 3, and we have folks that are, like in their 70s, right? In terms of how that kind of is intersectional with intimate partner violence or domestic violence is often we are seeing both of those things in the folks that we serve, and sexual violence certainly can be a form of like intimate partner violence and domestic violence that is used against the population that we're serving. And we are serving folks who are undocumented, folks that are economically vulnerable, women of color, like across the, the spectrum, and Black women. And so part of what we see is there can even be like manipulation around their access to services, right? So they may be coming for individual services. Sometimes it can be hard, for example, for us to put together a group because the client's partner will say, well, you're already doing individual services. You don't need more services. You need to be in the home. You need to be doing this. Sometimes we have clients whose partners are showing up to services with them to kind of monitor what's going on. We've had clients' partners try to engage in services themselves, I think, in order to monitor what's going on. So that's kind of the intersection that we see. And so often what we're doing is we have a number of our staff that are cross-trained and have done cross-training. We have partnerships with like South Suburban Family Shelter, with Family Shelter in DuPage. We've done work with Latinas Mujeres in the past. I'm a little disconnected from what's happening in the city, but when I was there, we were doing cross-training with them. And so we do some of that psychoeducation with the population that we're serving, then we're often trying to refer them to the services that are locationally like most available to them, and encouraging them to engage in those either simultaneously with our service or sometimes to do that before so they can kind of stabilize with that and then come back and do some of the sexual violence work, trauma work with us.
Okay, thank you. So you all have a very broad reach across Chicago and the surrounding suburbs, and I really appreciate that, especially with communities of color and transgender and male and female, recognizing that male and females and non-gender conforming people all experience violence to some extent in some form. So everyone can be affected by this. I'd like to talk a little bit. So I want to spend the bulk of our time being COVID related. Granted, we all know that there is an increase in violence, all kinds of family violence, child abuse, elder abuse, and intimate partner violence now since we've got quarantine and increased anxiety. And it's a big concern, obviously for pregnant women. I'm an obstetrician, so that is even more of a concern as well. But I'd like to talk about for a couple minutes, maybe each of you can just take your talk a little bit about screening and how, do you have any tips on screening for like in healthcare settings or in other places now that we're doing telehealth outreach, and helping somebody realize or get through that process of the relationship being unhealthy or dangerous, things like that. What can we do? If you could speak to the clinicians and the screener, the people who can help refer, what can we do? Radhika or Linda or Rachel, who wants to go first?
We're going to hear more from Beth at CAWC, since they have the partnership with Northwestern, but she can tell you more about their programming. But I would encourage all healthcare practitioners to go to the Futures Without Violence website, and we can share that link. They have a Healthcare is About Domestic Violence, a beautifully laid out set of multilingual resources for clinicians on screening. But one of the things that we've recognized is that it's not just when you are being abused in an abusive relationship that you have a variety of healthcare issues that are often caused by or exacerbated by the abuse. So the screenings that ask, have you ever been? And then Dr. Sonia Oyola, our guru in the domestic violence screening in clinical settings in Chicago. She encourages people to pause between each type of abuse that they list. Have you ever felt threatened, yelled at, forced, et cetera, et cetera? Those are some of the overall things that we recommend. Also, we recommend that in any clinical setting, if the patient does not speak English and does not speak a language that the practitioner speaks, rather than relying on the person who's come with them, if many of them might bring somebody with them, rather than asking them to interpret that, the medical system uses their language line. As much as possible, we want to be able to have the patient be able to speak for themselves whenever possible. And so each clinical system can decide, how to do that. And Beth can talk more about how they've, been doing that work in clinical systems for 30 years. But those are some of our overall recommendations.
Thank you. Rachel, Linda.
So I can go next. I mean, I think Radhika highlighted some really good points. Definitely making sure that the survivor in the hospital or health setting is as comfortable as possible to find out and assess whether or not that person is a survivor is really important. Comfort. I think to talk a little bit differently about this too is that we at Mujeres have opened up a third site with the federally qualified health center, Esperanza Health Center. And the idea behind that is that, one, I think that health providers, both community hospitals, larger university hospitals, and medical centers and FQHCs, federally qualified health centers, are really jumping on the bandwagon that we've always talked about, that domestic violence is a public health issue. I'd also say it's a public safety issue, but let's not go there. And as a public health issue, we really think that hospital settings or healthcare settings are great ways to screen or assess if somebody is a survivor. And I have seen this both with women, transgendered, and men in the hospital or healthcare setting in our community. And so for us, what we've done is we have a first floor suite at Esperanza's new site in Brighton Park on 47th in California. And the mental health professionals and the nurses know that they can come down to Mujeres and ask for an appointment with one of our domestic violence staff members, whether on site or later that day. And so I think that for us, just having that ease, or that kind of like that warm handoff, is really important. Now, granted, not every domestic violence organization can be in a hospital or a healthcare setting, but what it shows is that there is a trust that's within the organization, that there is a higher likelihood that if you have that warm handoff, that person will actually receive services. And having said that too, Mujeres has been part of training processes, not just for health centers, but also for health promoters, so people who are doing health outreach, what we call promotores de salud. But we're also seeing more requests from hospitals just to train their staff. Some of them are licensed clinical social workers or licensed clinical professional counselors, or just bachelor's level counselors that the hospitals have hired to provide more of a social work or a community counseling approach to how they do their care for their patients. And that's something that we've really jumped upon as well, is the opportunity to just educate more folks about domestic violence, but also placing them in, making sure that those health professionals feel that they know who to call to or go to or do that warm handoff with, so that the likelihood of that participant seeking care increases.
Yeah, no, warm handoffs are important, even in people experiencing homelessness as well. So, and for other supports. So that's a very important point. Thank you. Rachel, do you have anything to add?
One of the things I would add is recently, as I'm sure a lot of folks maybe here who are service providers are dealing with as well, as we've had to switch to providing telehealth. We were already working towards doing that, and then we really had to kind of speed up and ramp up that process with everything that's going on, right? And so one of the things I would just kind of have folks, keep in mind is our governing body specific to sexual violence is ICASA, so the Illinois Coalition Against Sexual Assault. They have rolled out like a telehealth policy and a training. So they were already doing that before this happened. So luckily we were able to get some of that done in February. And one of the kind of pieces they've put in place that I think is important to think about in general, but also especially when we're thinking about intimate partner violence, is working with the person you're serving, if possible, to come up with code words so that you know if they're in a private place, if they're feeling safe, having a protocol for really making sure that the space is confidential and safe for them, and if not, them having a mechanism to be able to communicate that to you in some capacity. So as we're all kind of now becoming familiar with Zoom and Teams and all these other like platforms that we're providing services with, I'd encourage people to really think about that when they're working with clients, like working out a protocol ahead of time if possible to make sure that they're able to communicate that they have privacy and that they're safe, or to give you a code word if they're not, and maybe having some kind of plan for how you can communicate from there if they're signaling to you that they're not safe or they're not private and it's not okay.
So can we dig into that a little bit? That's where it's a great entree into now spending the next 10 minutes or so on COVID specific, like how do you put these code words? How do you figure that out? And if a code word is said on a check-in, because quite frankly, like health systems like ours are doing the COVID check-ins for people, and our people who are working those lines are hearing a lot of domestic violence or IPV issues come up, and they're not equipped to handle it. So how do you put that in place, and what kind of code words, and then what do you do if that code word is triggered?
Okay. So I would say, let me just preface this by giving some context. So we kind of got this training and started to put this in place with clients we were already seeing. So that's something you have to think about it differently when you have new folks coming in the door. So a lot of the conversations that we're having with folks we were already providing service to, we kind of already have some knowledge of what's going on with them because we've been providing them service. And so then we're having conversations like, if for some reason you're not private, or for example, when we first started this, we didn't have video capability yet. It wasn't approved by ICASA. We were getting, we had some infrastructure there, but it wasn't there yet. So we were doing all this over the phone. So we couldn't even see our clients, like we're providing phone-based counseling, right? So the code words and kind of ensuring privacy was even more important then. Part of the way that we've embedded that is in our initial consent forms. We now have rolled out, I think it's called an electronic services opt-in form. And so we discuss at that point in time, like, do you have a private space? Do you have any safety concerns? If you don't, it kind of prompts you to start talking about all of those things to lay the groundwork. So that's how we're kind of working, how we're working with existing clients and with new clients, is that's kind of rolled into our intake process. And then from there, if folks are indicating like, hey, no, it's not safe, or I don't have a private space, sometimes it's brainstorming, so, we have some clients that are like doing services from their car because that's the only private space they're able to get to. And some of that, may be because of violence in the home, but some of that just may be because of like life circumstances, right? Like people have children, they have these other things, and they don't want to be, opening up their trauma with their children in the room as they shouldn't be, right? And so some of it is brainstorming. Other times it might be resources. Like, is there an email that you have that your partner doesn't have access to that's going to be safe for you to check, and can I send you some resources? It may be things like that. It's also thinking about the code word in terms of, oh, if you say this, then this is what my response is going to be, right? It might be like, oh, I've had something come up, I'm going to need to reschedule our appointment, and then kind of following whatever protocol you all have sent. So it's thinking about how to work it in a way that ideally would be keeping your client safe, and you all have hopefully worked out some kind of protocol ahead of time. Part of our intake process is gathering email, and we're especially trying to do that now. We certainly are finding we have clients that don't have email, right? Or may not have access to technology. So sometimes it's actually helping them set up email in our intake process, so we have a way to communicate with them. And then it's kind of gauging based on their access to technology what we provide them. So we have protocols for if we're only working with clients over the phone, because that's all that they have access to right now, and protocols for clients who have some video capability and what that looks like. And I don't know if, the other ladies may have their own protocols for the folks they're serving.
Yeah, I'd love to hear both Radhika and Linda's take on COVID, how COVID has changed some of this dynamic and some creative ways to deal with this based on your particular populations.
I think I can't speak to current protocols, other than saying that it's really important to remember that the Illinois Domestic violence hotline, and many of our hotlines are also accessible by texting. And so it's really important to lay that out there when you are talking to somebody for the first time, especially if you're a healthcare practitioner dealing with many different health issues and you're doing safe follow-up care for COVID-19 patients, to say that we know that a lot of, like a general preface, we know that there are a lot of individuals and families or households that have been suffering, whether it's from food access, depression, family tensions, maybe there's a lot more conflict in the house. Please know that we have numbers that we can refer you to, and you can call us back at any time if you want more information. We can also send you a general info sheet, and that's one of the things that we're working on. We were approached by somebody who's wanting to work with medical students who are doing COVID-19 follow-up care, and we're looking at developing a general resource sheet, one of which would be the sexual assault hotline, domestic violence hotline, etc. So sort of embedded in a pretty innocuous looking resource sheet, but for those who especially need and want it, it will be some of the most essential numbers for them. Those are some of the ways that you can generally, in a universal way in the beginning, start to raise that up. When there is not social distancing, obviously we also encourage clinicians to offer their phone if people are visiting the clinic, to say, if your phone is being monitored and you want to call a domestic violence or sexual assault program or any other services, you can use our phones. If you want to keep things in your files here, including an order of protection, this is there are other things that we can keep. So offering the clinic space and clinic resources in other ways to provide information and to be a source of contacting outside resources.
Linda, do you have anything to add?
So, one of the things that we have seen is because we're working with a very large undocumented population, we have established a protocol that we are calling every program. So we have domestic violence, sexual assault, community engagement, Empresaria is an entrepreneurship program. 40% of them are survivors of domestic violence, and our parent support program, where we work with both DSFS cases and also all parents who, many are survivors of domestic violence and need support. Everyone is on a weekly basis calling up their participants to see how they're doing. So it's just a check-in. They may be doing okay. They may not be living with their survivor. They have maybe in counseling or therapy already for over a year. But because of COVID-19, everything is, there's no normalcy anymore. So we're checking in to see if they need anything and what we can do in terms of referrals. And what we have seen as a response to that is that folks are just very happy to have someone to talk to. And I think that is where, the mental health element or the cash assistance element that is affecting so many families is so important, is like, what can we do to help you? Maybe Mujeres cannot solve it. Maybe Mujeres can't give you the cash assistance, but we're here to listen to you and see what you and your family needs. And so far that approach has gone very, very well. Because of that, we were able to do a needs assessment of 511 of our participants. And we actually just qualified the data yesterday, and it's all because of COVID-19. How has COVID-19 impacted your life? And I think that that's something that, one, we'll be communicating to our stakeholders, but also I think that'll educate us as to how we should be working with our other partners. What are the partners that we should be strengthening our partnerships with, or looking for new partners? Because if anything has been taught to me in these last several weeks is that we really cannot do this alone, this work, and we need to expand the network. And we need to think about, how do we amplify our referral process, particularly for vulnerable populations, those that do not speak English, those that are undocumented mixed status, those that are unbanked, those that are homeless. The list goes on. And so we need to figure out how to do our jobs better. And in the process, advocate for them to advocate for policies that level the playing field, because just as Rachel was saying, is that the digital literacy in our community is not very high. People may have smartphones, but they don't know how to download a smartphone app. Maybe they don't have enough data to do Zoom calls, even if that was an option. That they may prefer WhatsApp or Facebook Messenger to texting. We need to be able to be nimble in this. Otherwise, we're not going to meet survivors where they're at. And so we can't expect people to come to us. We got to go to them.
Okay, thank you. One question from the audience, or one request from the audience to Radhika, if you can share a template of the electronic services or opt-in questions that you were talking about, that would be very helpful. If you could, yeah, I think you referred to
I'm sorry, a template of.
The opt-in questions, the electronic services opt-in questions.
Oh, well, okay, well, I'm not sure if they're asking about whether or not people can text the Illinois Domestic Violence Hotline, or if they're asking about.
I think
we're talking about
the sheet.
That was the form that I referenced in terms of the electronic opt-in services.
Oh, yes, yes, Rachel, yes.
What I can do is take a look at that and send out some questions that are on there.
Okay.
You know, to help guide folks. Maybe I can send that to one of the facilitators and they can email it out later. And I just wanted to add that the Chicago Rape Crisis Services hotline also is available via text for folks as well. So just in addition, if folks are struggling with sexual violence, that's accessible in that way too.
Now, I hear a lot about this. So, you know, Melissa, if we're going to screen for intimate partner violence or any of these violences, what if we can't do anything about it? Should we screen for it? And my answer is we should screen for it and listen. And just like Linda had said, you know, people, you can check in and, you know, you can at least refer to hotlines or some of your organizations locally, even if we can't just do something immediately about it. So what's your take on this? Because I hear it a lot. There is a massive effort across the city, specifically right now, and I'm part of the mayor's rapid equity response team, to start checking in with people, especially certain age groups. And if we call and we get something around violence, should we be asking? Go ahead.
Absolutely. I mean, the medical reasons are so compelling. I mean, for pregnancy, people who are exposed to intimate partner violence while pregnant have significantly higher rates of high blood pressure, preterm labor. Their babies are more likely to need ICU hospitalization and are a much higher risk of being injured. We also see much higher rates of sexually transmissible infections, and including HIV, amongst those who are exposed to intimate partner violence. So there's a lot of compelling medical reasons, and we know that regardless of, even if it's been years ago, people who are survivors of trauma, especially domestic violence, sexual assault, have much higher healthcare utilization rates, musculoskeletal, cardiovascular, gynecological, just a number of medical complications and need for care. So that alone is huge. And the most important thing, because I remember back in the 90s when I was working at a violence prevention agency and we were first working with the medical community to talk about screening, the typical response then from providers was, I don't want to open a Pandora's box. I got this much time and I've got a bunch of different things to cover. And so we think it's really important for anybody who's doing screening in a clinical setting to preface it with, I'm not an expert, but we want you to know that if you have ever suffered any kind of trauma, if anybody has hurt you in your life, it is likely to have an impact on your health, on your mental health, your physical health. And it helps us to know if that is part of your history, because it helps us to understand your healthcare needs. And so please note that now or any time in the future, if you want to talk about any type of abuse that's occurred, we have resources here for you. I'm not an expert, but I can give you information, just to kind of, do that sort of handoff and to say that. But it means so much coming from a healthcare practitioner that, look, I'm concerned about you, and this is directly, involved with your health.
Thank you. Linda, do you have any comments on that?
No, I think Radhika spoke really well about that. I think that for us, I think that we have to capitalize on the pandemic in one way. And I hate to say that, it's like what can we do better with our service sector? Domestic violence in some ways has been stuck in the past in terms of the way we do our work. I'm not saying, we don't do our work well. We do our work very well and in challenging circumstances, but in terms of like telehealth, we have been behind. And I think that this is an excellent opportunity for us to think about, when we're thinking about rapid response, telehealth should be part of that, counseling, therapy, making those how do we do the warm handoff electronically? How do we make that possible, but do it in a medium that doesn't scare off our participants that may not have a lot of digital literacy, that make it as easy as possible. I think that's something that we need to all think about in that way. And I think that for Mujeres and any other organization in DV that has like a community engagement element is how do we make sure that our promotoras de salud are part of that in terms of how do we give them the basic training that they need so that people can start having that initial conversation, say, hey, I'm not an expert, but I know someone who can help you. And that's okay. I think that's something that we should tell people. You shouldn't be afraid to ask the questions once you're trained, but just always say, I'm not the expert. Let me find you that. I mean, I'm an attorney by training. And when I would do orders of protection for my clients, I would, even back then I was referring to Mujeres Latinas because I spoke Spanish and doing that and say, you need the very best care. I am not a counselor. I want to refer you to someone. And I think that's what we need to start doing more, not to be afraid to ask those questions, particularly now where people feel more isolated, that we need to take more of that responsibility. So I think this is a good opportunity to what kind of new best practices can we launch in our sector? And this is the time to really try to model that.
Thank you. I'd like to have the time for the short slideshow that Linda has. Can we start that and then take audience questions? If you have any questions, please post them in chat. Hello.
That would be Beth.
Beth.
Beth presenting. Beth.
Okay, I will share my screen. Hi everyone. Thanks again, CHET, for putting this panel together and for all the insights that the panelists shared. My name is Beth Klieger, and I'm from CAWC, and I want to share a program that we have, the Hospital Crisis Intervention Project. So a brief overview of this program, HCIP. We first started in '92 at Stroger Hospital, and we were one of the first programs of this kind in the US. And then in 2014, we opened a second location at Prentice Women's Hospital within Northwestern Medicine. So what this program offers, we have 2 full-time counselors that are usually on site. Currently, because of the pandemic, we are doing telehealth, but still responding to referrals that we get from Northwestern Medicine as a whole. So what our counselors provide is crisis intervention, psychoeducation on IPV, safety planning, referrals potentially to legal advocacy, shelters, and more. And what that crisis intervention can look like is if we get a referral from a healthcare practitioner within Northwestern, bedside counseling, or coming to an outpatient clinic and meeting with that survivor in a confidential space, if that's something they would like. We then offer ongoing counseling sessions, usually at our office that is located on campus in Prentice Hospital. And right now we are doing ongoing phone counseling sessions. And we also offer that if that's most convenient for the survivor as well. We offer services in English and in Spanish, consultations for any department or staff member, and then trainings for any department within Northwestern Medicine. So on here I have the HCIP direct line, 312-472-1150, and this is still a way to refer patients or have consultations or trainings even at this time. So feel free to write down that number and utilize it. I know we had mentioned this a little bit earlier, and thank you, Radhika, for sharing. This is the Futures Without Violence evidence-based intervention. They created the CUES method, C for confidentiality, and I know we spoke about, again, really important to have a survivor in a confidential space, not use family members or anyone coming as interpreters for their safety. And even right now, with COVID that potentially if we can't have someone confidential via telehealth or screenings, then even embedding some of that information into a list of lots of resources might be a way to get information out. The universal education and empowerment. So this part talks a lot about having framing questions and many different kinds of questions that normalize that IPV is a health concern for many people. And there's a lot of tools online that talk about these different kinds of questions that healthcare professionals can ask, and also safety cards that can be downloaded. And then support. So we are happy to go more in depth with trainings on this method. But right now too, if you go directly to ipvhealth.org, you're able to get these safety card tools and other information. And then this is our contact information. So again, I'm Beth, I'm the Outreach Services Coordinator, and then our counselor, Elizabeth Meyer, and another counselor, Mary Elena Leone, are working still full-time and taking new referrals. So feel free at any time to contact us for trainings or consultations or referrals.
Thank you so much, Beth. Are there any audience questions? I can't see any. Well, I mean, I have more questions, so.
Hi.
Oh, go ahead. Go ahead.
We do have a couple audience questions. Do any of the shelters, especially Mujeres, serve any indigenous population? And if they do, is there any way my organization, American Indian Health Services of Chicago Incorporation, can help?
So just to clear, we don't have a shelter, but we are a domestic violence organization. Actually, that's a really good question. We're unlike, I think, the Plain states, so the Plain Midwest states or in California, we don't have very much of an indigenous population that we're serving here in Chicago. There's just not a very large number of indigenous speakers with among the Latino populations. And so we haven't had the challenges that are represented with language accessibility. That's not to say that there are not there's not that population represented in Chicago, but it's just very, very small.
Thank you. And are there any efforts underway to increase the number and or capacity of domestic violence shelters?
So that is a philosophical question because some folks argue that we have enough shelters, others do not. Some folks don't want to go to a shelter. So there's not a one size fits model. I think shelters should always have a place in the way that we approach survivors and domestic violence. That's what I think. But we have to offer other options, and particularly because we have to do what the survivor feels is best in their interest and is most comfortable with. Again, that's the approach that I think all domestic violence providers would say. So that being the case, what we've seen is particularly with the COVID-19 pandemic is that there are not enough shelters, there are not enough hotels, their need is great. And so what are we going to do long term to make sure that people are safe and they can thrive and they can be active participants in this new era that we're living in? So I think that for us, this is a great opportunity to raise awareness. And so it's good that there's a lot of worldwide attention paid to domestic violence. And I hope that stays consistent and actually grows and not diminishes during the pandemic. And I think a large part of that will be, how do we secure enough resources for the question about sheltering or hotel stays or short-term apartment stays, whatever it is that best makes sense. I don't know if Radhika, you're shaking your head a lot. I mean, you're nodding your head a lot. So I'm wondering what you think.
No, I'm yes, snap. I would add that a few things. There was a fabulous women of color organizing. It was a webinar last week called a panel from Majority Rising, and one of the international speakers from England. We're seeing that across the globe, after a pandemic, after warfare, after natural disaster, sexual assault and gender-based violence in various forms goes up. And what people are seeing is that with many lockdowns, public health lockdowns, about 2 weeks after the lockdown, there's this big surge in calls and people who are Googling, how do I get services, et cetera, various ways of seeing increased exposure to abuse. One of the things that I think we all have to be prepared for, one of the speakers on the panel last week said that, we know there are going to be these waves as things open up, and then there's a surge in infection, and that we have to be prepared, and as you said, Linda, nimble to anticipate that we need to have the resources in place so that when the second and third as subsequent waves of infection and illness increase, that we have to have the hotel rooms lined up, the apartments lined up, the transportation lined up, and the emergency kits and mutual aid, cash assistance all ready. We all know what has been needed and what the resources are that are most needed, and that we have to be prepared to have a much more quickly deployed response to all of the future surges that we know are going to happen as people come out of different stages of lockdown. So I think that those are some of the things that I think that we immediately know that we need to have ready, because they are going to be needed.
Thank you. I have another question. How would you describe the dynamics that can lead to abuse starting during pregnancy? And how do you think COVID-19 has changed these dynamics?
Rachel, I haven't heard from you in a little bit. Do you have any comments on that? I mean, it's clear that 1 in 6 about people who are pregnant experience intimate partner violence for the first time during pregnancy. So it is a risk. I don't see Rachel.
Oh, I'm here.
Oh, there she is. Sorry, my screen is on that.
Here. I think in terms of sometimes how we see this manifest, and I'm sure, Radhika and Linda could speak to this even more so than I can. Part of what we'll see is with any domestic violence kind of dynamic, including then when someone is pregnant, is lots of controlling pieces, right? So contact with others, control over medical appointments and whether they can go, control over supportive services, threatening physical violence because they know that there's even like higher levels of vulnerability, sometimes threatening to force them to terminate the pregnancy, threatening around like, well, how are you going to do this without me? Like, you don't have the resources, right? Like, how are you going to live? How are you going to take care of this? Da, 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 da. So, and I think sometimes too, even like a dynamic that we've seen leading up to pregnancy is like, I don't know if this is quite the right way, but kind of in a manifestation of like forced sexual violence is like forced pregnancy in some ways. Like we've had survivors who came in who, like their partner intentionally got them pregnant when they knew that they didn't want that against their wishes, right? And then maybe because of circumstances, values, culture, any number of things, they now feel like they have to carry through with this pregnancy. And then there's all of those things that come along with it. So that's some of what we see. And then I think certainly I'll speak both as someone who is serving survivors, but also as a mother. I'm a mother of young children. I've gone through 2 pregnancies. It's a very vulnerable state to be in. There are a lot of things changing with your body. There are things changing with your mental and emotional health related to all of those things. And I know, and then certainly as someone who historically, I started my career out serving children, and I actually worked for SAS. So I worked in screening assessment support services. And that's a program in the state of Illinois that serves kids that are at risk of hurting themselves or hurting others. Oftentimes we're showing up in schools or emergency rooms because there are kids that are at risk and need to be assessed for hospitalization. And so that stuff also impacts like a child's development in the womb and beyond, in terms of their ability to regulate, in terms of growth. I'm sure probably lots of folks have heard of ACEs. If you haven't, you know, it's a good resource to look up, and it kind of looks at when you've had these adverse childhood experiences, how that literally impacts, you know, like as Linda was saying before, it impacts your health. Hearing that from a health provider directly is really important, since often folks have thought about kind of your emotional and mental well-being as like these separate things that are like luxuries to take care of. And in some ways they are, because of how our system is built in terms of access, right? But it's not thought of like it's just as important as if you needed to address your heart, or if you needed to address your cholesterol, or you needed to address any of these other things that are important. So those are some of the dynamics that we see, is like, you know, forced pregnancy, exacerbation around the vulnerability, you know, potentially threatening to withhold resources around them being well while they're pregnant once their child comes, threatening to take their children. I'm sure you all could probably speak even more specifically to folks who are undocumented, and then talking about like, well, you know, we've had cases where folks have been threatened to, you know, like, I'll call ICE on you and then you won't have access to these children. We've had survivors whose children have been taken from them by like their partner just up and left and took the children, and they have no idea where they are and don't have the resources to kind of figure out how to get them back. So those are some of the things that we've seen.
Okay, are there any other questions before we wrap up? You all are, oh, go ahead.
Sorry, one last question. Are there any mental health providers that are free or low assistance for survivors and for abusers?
Well, all of the domestic violence services, you know, are free of charge. So domestic violence counseling, advocacy, legal advocacy, case management, you know, and, you know, shelter, et cetera, those are all free of charge, as are the you know, ICOSTA, the Coalition Against Sexual Assault funded programs. All of our services are free for those who have committed harm, who are interested in abuse intervention. There are, you want to look for PAIP programs, Partner Abuse Intervention Program, and there is a small cost that is assessed by some of those to participate as a group member, but it's not prohibitive. It's not super expensive, and the whole idea is that, you know, have some skin in the game. You pay something that's affordable to you to participate in the Partner Abuse Intervention Program. We need a lot more. We need many more interventions for those who've committed harm, but that is one intervention in Illinois that is funded and recognized.
I would also say that I think that there has been more talk, at least at the city level, in terms of increasing the referral process for individuals that may identify as people who have caused harm, to know where to get services. And so, for instance, domestic violence organizations may not have a lot of those referral agencies that they can go to when people do come, because we do get calls for people who identify as people who have caused harm who are looking for services. So I think that's something that has definitely improved. I think the other thing too is in terms of mental health. There has been increased funding at the federal level, so organizations like Mujeres can now start offering more of an intensive approach. So again, people who, you know, 10 sessions of counseling or 20 sessions of counseling is enough. They need to maybe be in therapy for a year or 2 years. We're dealing with a lot of folks who are undocumented, have no access to health care. And they are survivors, but they also have some other mental health issue that they need a more intensive approach that we could provide. And that is something that, you know, our master's level staff do. And I think that's something that more domestic violence and sexual assault organizations will continue to do, especially with the undocumented population and the underinsured population.
Thank you. So before we put up the slide of resources that we have, I just wanted to thank each of you. All 4 of you are doing such tremendous work for such an important thing. Radhika, Linda, Rachel, Beth, I want to thank you all for all that you do and all that you do to lift the health for everyone. It's just from the bottom of my heart. Thank you. These are some of the resources and contacts, and thank you. Thank you all for joining us today.
Thank you.
Thanks for having us.
Thanks,
Thanks.
everyone. And if there's any resources, websites, including the numbers that you see on the screen now that you might not have gotten to write down or take a screenshot of, we will be sharing today's recording along with these resources via email after this event. So you will definitely have a chance to review these if you didn't
And
get
on our website. And
on
on
our, yes, on our CHET website.